Good afternoon, everyone. Thank you for attending our webinar today. Um, I know we sent you a provocative solicitation that says, what if it happens again? My name is Tim Moore. I am with Smart Source. I've spent decades talking to hospitals about how they communicate with their patients and helping hospitals improve their patient experience. So I spent most of 2020 discussing the impact that the COVID pandemic had on hospitals, their revenues, their patient experience. So with that in mind, I kind of decided that it's better to be part of the solution than part of the problem. And so I have the opportunity today to have a discussion with Mike Laidlaw. And Mike is a decades of experience in revenue cycle management, in access management, and most recently, he was the director of patient access for a large Northern California health system. So I think history is a great teacher. So first and foremost, let's talk about what happened. So Mike, before we begin, can you give some idea of the order of magnitude of what you were trying to manage in early part of last year?
Well, at the time that pre-pandemic, we were handling about 1 million visits a year. And they were for 51 different departments in 13 hospitals. And the issue that always has come up is how do you handle things expeditiously and how do you manage process? So as you can imagine, with having over 1 million visits, there were a number of situations that arose. But fortunately, and part of what we're going to discuss today, is we were prepared for many of them before they started. So what I'd like to talk about today is pre-pandemic department development, managing the pandemic, and then lessons learned in preparing for the future states. So for those of us who have been in business for a while, Stephen Covey was an exceptionally good author, and one of his books was The 7 Habits of Highly Effective People. And he suggests in that we should always begin with the end in mind, which means to begin each day, task, or project with a clear vision of your desired direction and destination. Then you continue by flexing your proactive muscles to make things happen. So essentially, from my perspective, it's always been walking into a new situation, and certainly in this particular healthcare system, was to what do I want to achieve and how am I going to go about achieving it? So walking into any new place, there are two aspects of what I always look at. One is how do I streamline the processes, and then how do I automate them? I think many of you have heard of the idea and concept of lean, and some people have taken workshops, some people have been involved in different aspects of it, process improvement. Everyone calls it something different. Lean in and of itself is a little bit more complicated in that it is based on the Toyota production system, which has been around for a number of years and is involved in all kinds of industries around the country. So when you look at lean, the basic foundation is to eliminate waste. And to bring this home, I use the peanut butter and jelly example. And the peanut butter and jelly example has to do with how do you make a peanut butter sandwich? So do you go and gather everything at once? So you make one stop? Or do you walk back and forth to the pantry to catch each individual item that you're going to use? And then how do you make it? So in my first example, you'd be in a situation where you say, I'm going to get everything together. So I'm only making one trip as opposed to making many trips. So any trips you take is what's called a waste. So it's a waste of time. So what we tried to do in anything that we worked on is to lean out every single process. So many of the people who work in the revenue cycle know and understand that there's not one best way. There are many different concepts. There are many different ideas. From a hospital perspective or a medical group perspective, there are different ideas, different ways of doing things. And in our case, having 51 departments, all of whom wanted to do it a little bit different. So the first thing we did was go in and implement two aspects of lean. One is value stream mapping, which is taking an entire process from beginning to end and seeing how it works. Then the second part of it is to break it down into smaller pieces, which are called Kaizen workshops. And in Kaizen workshops, you take a process. There's a concept in lean called going to the workplace. So you go to where the work is being done and identify all the steps involved. In future webinars, we're going to speak to some of these concepts more from a actual example and to try and teach people. The second part of what I always tried to do is to automate things. Take any automation and implement it so that we can eliminate some of the manual processes. There's an old expression, if you give a lazy man a job, he'll find an easy way to do it. And I will have to say that much of what I've been able to do, along with my colleagues, is to take processes that are manual and very labor intensive and to automate them. So when you look at automation, you look at what is it that's a manual process that'll never be automated, and what are manual processes that you can't automate. I think we've all been to seminars, or we've been to HFMA or patient access seminars where there are vendor booths, and every vendor has something that they want to sell you. Typically, though, you can use currently available software that your hospital or medical group has that will allow you to do many of the things that we did. I was fortunate and have been fortunate throughout my career to have been able to budget for 1, 2, or 3 analysts. This is very different than many other places because there are IT departments that do your reporting and things like that. However, I've always felt that it's much easier if you can develop programs on the fly and be able to make good use of them. So I'm going to give you a couple of examples of that. And many of the people in the audience have Epic, or they have Cerner or other systems. And each system is a little bit different. And we have, within Epic, there's this thing that's called a work queue. And a work queue is a prompt for somebody to do something. And again, if I get a little bit micro, it's more conceptual so that you understand how you can do this. So there's what's called a schedule orders work queue, and many different things go in there. There are orders that have been sitting in there. There are orders that are coming in all the time. There are people who are canceling orders. So what we were looking to do is how do we speed up a process so that we are only looking at those orders that fall into the work queue from the night before. So we wrote a program that essentially looked at 12:01 a.m. any orders that fell into that work queue that were not old, so that we could use that as a tool to develop an uploaded file that we could send to an outside vendor to make calls or send texts. So from the perspective of doing 1 million visits, is it easy to make 1 million phone calls, or is it easier just to have a system do that? So we looked at it as automated as possible with the least amount of people. Now, when you're looking at a person, a person, depending upon your hospital or where you're from, I'm just pick Northern California, the cost of the employee plus the benefits is somewhere around $75,000. So if I have to spend $75,000 having people make outbound phone calls, then I'm not allowing people to take inbound phone calls. So if we could automate that process, that's kind of what we did. So again, it would automatically go out, it would make the phone call, and then the call would come back in again, via the patient. And with all the technology again, we were able to, as most of you are able to, touch a button on your phone, it will automatically dial in, or respond to a text and will automatically dial in. So we were able to increase our volumes by about 18%.
So let me ask you a question, Mike. So Mike, I'm curious, did making any of those changes provide any reduction in staff or enhancements that were unanticipated?
Well, actually it did. And one of the things we were able to do is save people. Because obviously, if you do not have that many people making outbound calls, you have extra capacity. So as I just mentioned, there's a cost per employee. And if you say you save 10 employees because now you've automated it, so now you've saved $720,000. What that allowed us to do is to take on additional work from other departments without having to spend the money on people. So the organization as a whole saved money based on what we were able to do at the time. So we felt, if you will, that between all of our automation, being able to use write fax instead of having manual orders, being able to use the reporting capabilities that are available from just basic Python or other types of software, that we were looking pretty good as far as how it all worked. So this was really up until about the 19th of March of 2020, we were really feeling pretty good about ourselves and about the things we could do and the opportunities to take on more departments and do more work because we had the electronic piece of it set up regardless of how a department worked.
So that's a perfect segue into the next, what happened. March 19th of 2020, Governor Newsom declared a statewide shelter-at-home order, and you had exactly 24 hours before the stay-at-home order took effect. Tell us what you did. Tell us how you managed it from that point forward, if you would.
Well, one of the things that had to happen as a result of stay-at-home order was that we had to take the 90 people who worked in our department, send them all home. So we were able to, within 3 days, and this has nothing to do with me, it was one of the excellent managers and one of our excellent project managers that were able to pick up within 3 days and move 90 people to home, taking with them all of their hardware and helping them with the hookups at home and helping them getting a home office set up. Initially, as we all recall, this was supposed to last for 2 weeks. And here we are a year and some months later, and people are still working at home. And the benefit there for our type of operation was you don't have to pay rent. So you now have a situation where you save money there. You also don't have to, in my case, buy a lot of coffee because there aren't people around there to drink it. So from the standpoint of view of what happened is we had to move everybody home. And then we had, based on the initial lockdown order, was to cancel 2 weeks worth of appointments. So when you look at this from what many other people did, was they would, in their departments, would go in and manually call every single patient and cancel that appointment and attempt to reschedule it. We did a little bit differently in that we already had programs set up so that we could go into all 51 department schedules and electronically download files that we could upload to a call company that made outbound calls. So rather than spending the time and effort trying to do that, we were able to immediately cancel all those appointments. So one of the things that happened as a result of this is for about 2 weeks, everything just went down. Departments weren't making any type of schedules. They were waiting to see what the orders were and what the local medical advice was. So again, getting back to my automation piece, is departments started to slowly open up. And departments would say, we can schedule 6 MRIs for today. And that's one department. Another department in a different hospital may say we can do 10. So there is within Epic, and I'm sure it's within other softwares that people use for hospitals or medical groups, is there's what's called a template. In other words, you set up each service with a template. So if you're going to do an MRI, in the old days, you could do it for 45 minutes, but under the new thing, you had to do it in an hour because you had to clean equipment. You now had to call patients into the hospital. I think we've all have experienced the questions. I think there's 5 of them. I've heard them so many times since the beginning of this, in terms of you've been exposed to people, have you had the sniffles, have you had any symptoms of COVID? So in addition to that, so when you're looking at it from a scheduling perspective, you now have added what's called lead time to a particular process. The average call we would take in the past was 4 minutes and 10 seconds. With all of the additional work that had to be done, as I said, asking the COVID questions, depending upon the hospital, whether they wanted the patient to wait in a car, giving them wayfinding instructions because they were changing how people could go in and go out. This added an additional 2 minutes. So when you're looking at the 2-minute addition, it now brings it up to 6 minutes. So when you're looking at the total amount of work that can be done, at that juncture, it was pretty easy because there weren't that many patients being scheduled. But after that, it became much more complicated. And getting back to the schedule part of this is that we were able to automate the process where if there was a schedule that was for 25 minutes and now it's going to be 35 minutes, we were able to go into the system and just make a change to flex to whatever time that they needed, and to also flex to the number of appointments that could be seen in one day. So again, this is a very detailed type of discussion, but the ability to be nimble, if you will, to adapt to changes is very, very important when you come into these situations. And we're talking about COVID-19, and I'm sure at some point we may be talking about COVID-27, but somewhat being able to adjust to on the fly, if you will, to whatever the circumstance might be, goes a long way towards making it significantly easier in the future.
So lessons learned. Let's sum up for the people on the call. What did you learn through the process?
Well, one of the things we learned, and it's been something that's been somewhat endemic in our operations, has been the ability, if you can, to hire your own internal IT staff and provide them with the necessary training. I still have one particular person who I sent to Wisconsin in the middle of the winter, who still is not very happy with me because it's very, very cold, very, very icy at that time of the year. And she was from California, so it wasn't exactly a pleasant experience. So from the perspective of training, is you give them as much training as they need. If there are tools available, then if they want to use those tools. So just Excel is fine, but if you get into, in the case of Epic, there's crystal reporting, there's a number of other reporting tools that you can use and software that you can develop yourself, make these things go faster. My thing, I think at the beginning of this conversation, is to lean out everything that you can. And so that you would know that all of your processes are working at 100%. You should also quantify what your savings and productivity is at all levels. If you can save $1 million a year for a hospital or a medical group, and you can also, by the fact that you can work from home and do the same quality of work, save money there, it is a significant savings to a hospital. The other thing we've done, and I failed to mention this earlier, is that if you're making all these outbound calls, then you have to know that you did call someone. So we employed one of they call them AI applications now, and it's called robotics process automation. So we developed a program that would take calls that were made and go into the system without people doing it, and what's called call increment. So we can say that we called him once, then we called him twice, then we called him the third time, depending upon what the department wanted to do, and then we could move you off to a no-call list. The other thing that's been really somewhat, it isn't new, but I think it's new to hospitals and medical groups, the idea and concept of using bots, which you can pretty much use 24 hours a day, 365 days a year. So that is an application that just before I left, we started to look at. And I know that, I believe that Tim has some companies that he works with that deal with the bots, which again reduces the number of staffing levels.
Yeah.
So this is kind of the lessons we learned, was that going into COVID, we were pretty well prepared as far as making any type of change. And by adding new tools and providing the staff with new tools, it just made our process that much easier.
So, okay, so to sum up, nimble, automated, and keep trying to add tools to your toolkit. I appreciate everyone's time on this webinar today. If we didn't get to your questions, we'll answer them offline. If you want to reach out to Mike or myself, we're both very interested in helping hospitals and providers handle the new world that we're in. And with that, I appreciate your time, and we'll go from there.